I'm back. Sorry, I had to break this up into two videos. Next thing we wanted to talk about, wrote some notes over here so that I get all the terminology right. There's a lot of terminology. There's a lot of abbreviations and things like that you're going to come across and hear in different clinical settings. So I just wanted to go over some of them with you and give you guys an idea of what you're going to hear and what it means. So you're going to hear the term CMS, you're going to hear the terms PPS, you're going to hear RAC audit, you're going to hear FI, you're going to hear just all sorts of different terms, and people throw them out like everybody understands what they are, and it takes time to learn them and understand them and know what it means to you as a therapist and what you're going to have to do in response to some of those things. So first off is PPS. PPS just stands for Prospective Payment System. At this point in time, it's kind of an antiquated term. It deals with the Medicare RUG classification system that we discussed earlier. And prospective payment, it used to just be that we had RUG periods that we did a 5-day assessment, 14-day assessment, 30-day assessment, 60-day, and 90 days. So, we had 5 assessment periods, and that's what set the tone. And that's what they meant by prospective. We would do, like a 30-day assessment period, and that period would pay then from day 31 all the way to day 60 with no other intervention, no other check to make sure we're doing what we're supposed to. We've really come into a system now that isn't the case anymore. We're having to do weekly updates and make sure that the minutes that we're providing are still appropriate to the level of care that we said that we're billing for. So if those levels change, we have to do what's called a change of therapy assessment, and it resets the RUG not prospectively anymore. It resets it for what we have done. So it will go back to previous 7 days and change our RUG level for what has been done. So like I said, the PPS system, they really need to change the name because it's not prospective anymore. Now it is like I said, it does have some prospective components to it, but it really has come into something that we're monitoring every week, and if there's a change in the level, then it has to be changed for that previous week. So CMS is Center for Medicare Services. You'll hear people talk about CMS. It's kind of an encompassing program. It deals with all of your Medicare type patients. RAC. You'll hear the term RAC a lot. It's a big buzzword now. RAC audits. Everybody's worried about RAC audits. We got a RAC audit. What are we going to do? Oh my goodness. And it can be scary, especially if you're thrown into it as a student or as a new grad. It stands for Recovery Audit Contractors. Now, these are the people that work with, they're contracted by CMS, and they work with CMS to go back and make sure that as a nursing home, what we say we have billed is what really happened. So they'll come back and they'll look 3 years ago and go, we don't think that what you billed matches what we think it should have been. They're using computer algorithms to tear through billing and really try and find any discrepancy they can find to justify them coming in and going, hey, you need to send us documentation supportive of why these services were provided. It's gotten here in the last year and a half to 2 years very aggressive. A lot of these RAC organizations get a percentage of reimbursement from what they recover from Medicare. So based off of that, you can imagine that they're not totally unbiased. They're definitely looking and trying to find different reasons to justify an audit in your facility. And a lot of times it'll just come, they'll get a paper request and go, we just need to review this stuff, and they'll send you some patients, and typically they'll look at about a month at a time, and they'll look at those, and those are basically just feeler programs. They'll send those out and see, you'll send the information in, and they'll see if there's anything there to justify needing to reimburse for any services that they have paid you for. Now the kicker is, if they start finding that, you know, we have to pay back services for certain periods of time, then it becomes a much more in-depth process, because, you know, they're sending out, I don't know if you, I'm a big fan of The Deadliest Catch, and that's all I can equate it to in this process is they're throwing nets out there, they're throwing cages out there just to see what they can find. And if they find an area that they're pulling back a lot of money from, then they start setting all their traps there. They're going to start sending letters to you for everybody. They have thresholds that they look at. So if they send you 10 and, you know, you don't have to pay back anything on 8 of them, they're going to walk away and they're going to go somewhere else. But if, you know, typically if you're under 60 to 70%, they're going to then just start coming and looking at more and more patients, and you know, it really puts your facility, your company at risk of having to reimburse a lot of money. So that's what you're going to come into regarding RAC audits, and we'll discuss in a minute what your, as just a treating, evaluating therapist, what your role is in helping through that process. You know, we've discussed rug levels, CPT codes. The other thing you're going to hear, you may still hear the term ICD-9 coding. I'm assuming that you guys have probably by now been exposed to diagnosis coding, but if you have not, you need to start looking into that, and we'll discuss it more in depth live. But we have gone past ICD-9 coding now. Nobody should, I shouldn't say nobody, I have ran into a couple of insurance companies that have still requested ICD-9 codes, but by and far you're going to be dealing with ICD-10 coding, which on the surface is a great deal more complex than ICD-9. It gets into much more specifics regarding each diagnosis, and you know, whether it's a new onset, post onset, if this is aftercare, intermediate care, you know, it is an extremely in-depth diagnosing program, but it's really putting us on par now with a lot of the other countries and how they do their diagnosing, and it'll help us be more comparative to understanding if our healthcare systems are on par with what other countries are providing and things like that. So it gets us into a more universal concept with at least diagnosis coding. So but because of how expansive it has become, it used to be you just remember your diagnosis codes. You know, we had some standard go-to ones for therapy, you know, difficulty walking, apraxia, you know, for speech therapy. You used to just be able to use dysphagia or symbolic dysfunction with no other determination. It has gotten so much more in depth than that now. You know, with dysphagia, you have to break it down into the actual component that where the swallowing dysfunction is. You can't just say it's dysphagia. You have to get more in depth, and certainly we can discuss that more live, and Joe can definitely Dr. Shackelford can definitely go more in depth into those diagnosis coding. But before we meet live, you know, we've already talked about reviewing CPT coding. The other thing you need to do is, I'm sure most of you have smartphones, I'm imagining. They have some very good free ICD-10 coding apps for the smartphones. So go ahead and get one of those. Just start playing around with it. You know, look through the medical information that you guys are learning and see, just taking a very basic patient and just, you know, looking at it, using those search features and things like that, and just start familiarizing yourself with different diagnosis codes. And we'll discuss too, the ICD-10 coding uses multiple digits now. You've got 3 digits prior, or 4 digits prior, 3 digits after the decimal point, I believe. I guess I need to look at that again. But anyway, just start looking at those, because each decimal place means something different. So take a look at those. Try and get yourself familiar with ICD-10 coding. That way when we discuss it live, you guys will already have a familiarity with it, and we won't have to be learning it from scratch. So just play around with it. It's kind of neat. They've got some just bizarre codes on there. One of them was death by being sucked into a jet engine. They just have some bizarre codes in there now, and it's kind of neat to stumble across some of those. So, go ahead and take a look at those and start to understand what it is that you're going to have to provide in the clinic. So we've discussed some of the terms that you're going to come across. So when you actually get into skilled nursing setting, you're going to be required to do documentation. Some places, I think there's still a few that are left doing it on paper. Most have gone to some digital systems. Two of the main that you're going to come across, there's one called Rehab Optima, and there's another one called Kasamba or Smart, depending on what company's using it, but it's the exact same program, Kasamba/Smart. So that's the one I'm most familiar with. I have a little bit of experience with Rehab Optima. It sounds like I'm going to be getting some more here pretty soon. The company I'm with is going to be switching to that. So just be aware that the digital documentation will take some time to get used to. It's very easy on paper to get things done quickly. The digital documentation, it is easy to get things done quickly. The problem is the learning curve into getting there. So you'll really have to understand exactly what it is that you're wanting to write to be able to put it in there. So most of your documentation systems are going to have some preset goals. A lot of therapists, they initially get exposed to it, don't like it. I want to write my own goal. I can do it better than this anyway. Well, what you need to understand is a lot of those preset goals have been formulated in a manner that they meet all of your Medicare requirements. So in order to satisfy those Medicare requirements, there's certain things that your goals have to include. So the companies have gotten very adapted, through the years of going through audits and denials and things like that, and understanding the key components for goals. So I would definitely, as a student and as a new grad, take advantage of what's in there and build upon it. It may be that there, some of the programs don't have what you want, and you'll have to learn how to build upon that. But just know that they do have the ability to be adjusted. The goals can all be worked with. The goals can all be rewritten. Various levels can be recorded in percentage of completion. They can be recorded in the number of trials that they completed. So just take note, take the knowledge that you're learning and try and adapt it to the software that you're working with. So one term that came to me while we were talking, or while I was talking about some of the evaluation, is term fiscal intermediary. You're going to hear that term, and it relates to your documentation as well, because your fiscal intermediary is the person that is an intermediary between your facility's billing department and CMS. So all of your billing goes from your facility to the fiscal intermediary. They run the billing through their system, make sure everything's okay, and then if everything checks all their boxes and goes through, they send it on to Medicare and you get paid. Now, they're different from the RACs. If they see a problem, they notify you immediately. You have an opportunity to correct it and resubmit the information so that they can bill. Now, the RACs come in after the fact. There's nothing you can do about that. But your fiscal intermediary sets the tone for how you can do things. So different fiscal intermediaries have different requirements for evaluations, different requirements for notes, and your facility's rehab manager should be able to explain all of that to you, or the facility's billing office should have that information as well. But just be aware that it's possible to be in one geographic location, like Bowling Green, and have facilities that have different fiscal intermediaries intermediaries. Now they're typically, the fiscal intermediaries are typically geographic, but companies can have a global contract. So, you may be working for a company that's based out of Minnesota, and they just happen to have a contract down here in Bowling Green. So they're going to use the fiscal intermediary that they have for Minnesota for all of their company. So, like I said, it can vary. So you may have a therapist go, oh, well, I use this code all the time. And you might be thinking, well, I can't. They can't use it either. It may be just a difference in the fiscal intermediary. So your ICD-9 or ICD-9, your ICD-10 codes will vary as far as there's certain codes that fiscal intermediaries don't allow. So it may be a legitimate ICD-10 code, but it's just that your fiscal intermediary has said, we're not going to pay that. We're not going to pay reimbursement for that code. So you have to make sure that your codes meet the criteria. Now, most of the time our software is set up to block the codes that don't meet the criteria, but just be aware that sometimes you may be asked by, a lot of times, your rehab manager like me might come to you and say, hey, you build this code, it's not going through billing, we need to find another code. It's okay. You're not doing anything wrong by finding another code. You're just working with Medicare to make sure that patient's being treated, and it just has to be processed in a certain way. So you may do an evaluation with a certain diagnosis code just fine. Sometimes it could be they need one more specific, or they sometimes have multiple codes that all describe the same condition, and you just have to make sure that you find one that describes the same condition. And sometimes it could be that you can't use a specific code on its own. Cognition is one of them that comes to mind. There's a few cognitive codes in ICD-10, and some of them fiscal intermediaries will not pay on if that's all it is. But if you combine the cognitive code with a good medical diagnosis code, then they process it without a problem. So just work with your facility, work with your rehab manager, and they'll be able to walk you through the process. But I want to make sure we hit while we were talking about documentation. So Medicare requires an eval on every patient, and you can write that eval per Medicare's guidelines for up to 12 weeks of service. Sometimes companies have a different requirement as far as what they require. Some don't want you to do more than 30 days. Some don't care. Some may say, well, your short-term goals can't be longer than 2 weeks, and your long-term goals shouldn't be any longer than 6 weeks. It's just that's really up to the company and what they have found to be had the most success with getting reimbursed. I know Medicare is really starting to look more closely at our short-term goals, because sometimes you'll have people write a short-term goal for 6 weeks. Well, that's not really short-term by definition. So we have to start paying more attention to those things as our services are getting looked at a lot more closely. And we have to start making sure that we're providing the level of care that's appropriate, and providing the information. It could be that our short-term goal, we just need to break it down smaller. That well, maybe we don't need to get them that far before we progress the goal. So we have to start looking at smaller increments and doing things like that. So. The other thing with documentation that we have to pay attention to is progress. Our biggest barrier with Medicare, and the reason for most denials is from lack of progress. So basically what that means is when Medicare comes back, or our RAC auditor comes back, and they look at all the information that we've sent them, they'll say, we're okay with paying for the first month and a half of care for this person because they were making progress, but that last 3 weeks we didn't see any progress at all, and you didn't start discharge planning on that patient until after that time. So they may just say, we're not going to pay for that last little bit of time because you should have been working on discharge planning during the course of that time. So progress is a huge thing, and that kind of ties back into our goals and how we write them. We need to make sure that It's all written so that from the evaluation through each of the progress notes and all the way through, if we have to do a recert, which we'll talk about, or into discharge, that we can show the story, that we can show that patient from start to finish, that undeniably that without therapy's intervention they were not going to progress and not going to get better, and we have to tell that on paper because that's all we have. We don't have this opportunity like I have with you guys right now that I can sit down with Medicare and go, listen, let me tell you, no, we didn't document it, but my gosh, this patient started out just completely debilitated, and at the end they were playing hopscotch out the front door. Medicare doesn't care. They're looking at what's documented. If it wasn't documented, it didn't happen. So, if the goals aren't written well to show the progression and show that patient's improved, then we don't have a leg to stand on with Medicare. So, I'll bring some stuff to our live meeting that will give you a little more insight on documentation. I've given Joe some sample documentation. I'm so sorry, I keep saying. I've given Dr. Shackelford some documentation on some samples on evaluations and things like that hopefully allow you guys to look through it. It came from Kasamba. So, the reports that you're going to get, the way the evaluations are going to look from Rehab Optima are obviously different. I may be able to get some examples of those before we meet live, and I can upload them for you. But, just be aware that documentation is specific to one program. So, progress notes through Medicare, they're required through Medicare every 2 weeks. Every 10th visit, basically. And a lot of companies do them. They do a progress note every week. It really depends on how your company's set up. Most other companies that I work for, we do daily notes. So every CPT code that we bill, we write a daily note on. And so that satisfies a lot of Medicare's requirement and can allow you to push that out to 2 weeks. But if you're not doing daily notes, then you're going to have to do weekly notes. So, it just depends on what your company is set up for, but just know the company's policy for those notes is so they stay in compliance with Medicare and also at the state level. Medicare has requirements for documentation. The state, the various boards at the state, the Kentucky Board of Physical Therapy, Occupational Therapy, and Speech Therapy all have requirements for documentation. So whatever the most stringent requirements are what you're required to go with. If Medicare's requirements happen to be more stringent than the state requirements that you're in, then you have to go with Medicare. If the state requirements are more stringent than Medicare's, you have to go with the state. So whichever ones are more stringent, but your company should be looking into that as well. But it's not bad for the therapist just to pay attention, because your company's, your state boards are going to change things periodically, and sometimes if you're with a big company that's, I've been in one that was in all 50 states, so it's very difficult sometimes for them to stay up to date on what every single state's up to. They do a good job with it, but it doesn't hurt for you to be aware of what those requirements are as well. So but you got your evaluation, you have weekly notes or daily notes. And the weekly notes are, really just address every goal that's on that plan of care, where they were at last week, where they're at this week, barriers, why they didn't make more progress. If they're not making progress, what are we doing to either change the goals or ensure that they make progress by the next week? And then we also have recertification. So say you wrote the initial plan of care for 6 weeks. The recertification is going to be due when that 6 weeks is up. Now we either have to discharge them at that time or we have to recertify them for more therapy. That's a lot of times up to you as a therapist to decide whether they need continued treatment beyond that point. So the other... And it's basically the recert is basically an evaluation, but especially doing it electronically, a lot of that information you initially put in carries over, so it's not as much work as it sometimes can be. So The other thing that you're going to have then for documentation is a discharge summary, and that's really where we bring all that information together, short-term goals, long-term goals, really speak to any barriers, make sure we've got a great statement as to their discharge status, where they're going, why they're going there, and really looking at the whole patient and making sure that's our last chance to paint a picture. That's our last chance, and really put some effort into it and make a summary of, hey, they started here, we progressed, this is where they've ended, this is all the great things that we did, and this is why, it took this amount of time, and really putting that effort in and making sure that we've really brought to life what that patient went through while they were with us. Okay, so we've talked about the different payers that you're going to come in contact with. We've touched briefly on documentation, and we've discussed some of the various terms that you're going to come across, but I'm just really in the video trying to give you guys an overview of what it's going to be like. So in preparation for our live meeting together, just don't forget, I want you to review CPT codes. You need to probably have a list handy as to the different speech CPT codes that are available to you. Take notes in the videos as far as what the different RUG categories were, and I'll explain in a minute why. Also, ICD-10 coding, familiarize yourself with ICD-10 coding, and focus a lot on the speech aspect of it. The medical diagnosis part of it, the facility should be getting those, but it's just a matter a lot of times of looking up what those diagnoses are. But look at the ICD-10 coding and focus on dysphagia, aphasia, cognition, different cognitive impairments you might come in contact with, and look at the different variances in those ICD-10 codes and just get familiar. I'll see if Dr. Shackelford can upload those the sample documentation. So what we're going to do when we get together in chat live is I'll answer any questions that you have related to these videos. The other thing is we're going to go through a scenario where you're a therapist in a facility. We're going to have a mock patient, and we're going to kind of go through what the process would be. How would you do the evaluation? Coding the patient. What CPT codes would you recommend? How you would determine how many minutes the patient needs. While I may try and push as a rehab manager for patients to get as much as possible, there has to be a methodology in place for therapists to be able to look. And just to give you a basic idea, I would say in different clinics that I've been in different facilities, most every patient is going to get physical therapy and occupational therapy, because that's what they're coming in there for. Speech therapy, stroke patients, dysphagia patients are easy to find for speech therapy, but as a therapist, what are the things that you can provide, and how are you going to be able to help that patient, even if they don't have one of the glaringly obvious diagnoses that you're going to go into? What can you do for that patient to help them get better, and sometimes it's even to help PT and OT be able to work with them. If the patient is an ultra-high patient and they just get PT and OT, it's typically going to be 72 minutes a day for each discipline. So speech therapy coming in and treating a patient, we have to redistribute how those minutes play out. So if it's typically for me, if it's a 3-discipline patient, PTOT, ST, I will typically divvy out the minutes, 48 minutes per discipline per day. So when you do that, that gives you the required minutes that you need for the week. Sometimes, maybe speech therapy goes, we only need 30 minutes for this patient, and then we can distribute more patients to PT or OT or both. And sometimes it could be, hey, PT says they're too they're too involved right now. They're not able to do some of the stuff that I need them to do, and maybe you guys can pick up and you're going to work more on feeding and some of the memory issues and things like that. So just start thinking about those things, how you're going to help try and troubleshoot those patients, and how you're going to help formulate what rug level and how many minutes those patients are going to need for treatment wise for speech therapy. So that's going to be the focus. So you're going to look at the rug levels, make sure you're familiar with those CPT codes, ICD-10 coding specific to the ones that we talked about. And we'll get some information up about documentation, and just start thinking how it's going to play out in the clinic. You're going to have guidance when you go out, obviously, but sometimes you'll go into a clinic and you're the only speech therapist. Obviously not as a student, but as a new grad, and it can be intimidating. So we'll start walking through that. So bring any questions that you have. Most anything you want to know about Medicare, rug levels, CPT codes, all that kind of stuff, I can answer. Coding, documentation. So anything that you've seen, anything you have questions about, go ahead and bring that, and we'll also work through a mock patient and make sure that you guys have a good understanding of exactly what it is that you're going to be doing, documenting, and really trying to pick out how those patients are done. So thank you very much. I look forward to speaking to all of you, and have a good day.